Welcome back to part 3 of our series. We've touched on a lot of information so far. We've addressed and identified the epidemic of cardiometabolic disease, which encompasses cardiovascular disease and metabolic disorders such as type 2 diabetes, chronic kidney disease, and non-alcoholic fatty liver disease. We've also identified why identification of these diseases and risk stratification are so important. Dr. Jessie Sorolia is back with me today to talk about the how we utilize laboratory insights to identify disease earlier and risk stratify our patients. Welcome back, Jessie. I'm excited to talk about the how with you today.
Thanks for having me. I'm really excited to be here.
I know we're not going to have time to talk about all the laboratory insights you're utilizing in clinic. So I'll let you choose. What are the first labs that come to mind when you start thinking early identification?
So I think standard labs that come to mind when we're thinking cardiometabolic are CMP, a lipid, and A1C. But when we're thinking about early identification in patients that we may not easily identify all the time, such as younger patients, patients with family history, those risk factors that put people at higher risk with just by virtue of being born, I think we really need to think of like the IR score. Sometimes even the advanced lipid panel is what I do a lot of times because it gives a great visual to patients that you may have not initially thought they would be at risk. It also gives you a lot of cues for you and for the patient to talk about lifestyle changes a lot earlier so that you're preventing any progression of disease. Some of those patients need to be treated a little bit more aggressively too. And so we're preventing stuff in the long term.
So insulin resistance panel with score, which likely for the rest of the our conversation, you're going to hear us refer to it as the IR panel with score. And in addition, advanced lipids, right? So, you have multiple different laboratory insights that we can use outside of status quo, right? We have the CMP, we have the lipid panel, we have the A1C, but that's not always catching disease at its earliest. Would you agree?
Oh, 100%. I think that even if you're thinking like insulin resistance, it shows up 10 years a lot of times before even prediabetes shows up. We think prediabetes is like before diabetes, right? But honestly, like somebody could be pre-diabetic for a year and then the next year they develop diabetes because maybe they were insulin resistant for so many years prior that we didn't capture them early enough in order to prevent that progression. And now we're chasing the disease and we're not being as beneficial to the patients. And then they're frustrated and we're frustrated. And then you're just constantly adjusting medications as opposed to focusing on that preventative piece. I think a lot of people go into medicine for that preventative piece, and we have such an opportunity to do that.
Yeah, and it's really all about finding the laboratory insight to do that, right? And as we evolve as a medical community, diagnostic community, we are getting better at our ability to identify disease early. The IR panel with SCORE, this test can play a vital role in early identification. Given the epidemic of obesity and diabetes, this test can be huge in figuring out where your patient is on the pathway to diabetes. Before we get into test details, I think it's imperative to kind of discuss insulin resistance for a second. What is insulin resistance? In primary care, I really feel like often providers sit and wait. They wait for the traditional markers such as a fasting glucose or an A1C to be abnormal, when in reality, beta cells in particular are working harder to maintain glucose homeostasis. As you mentioned, that could be 10 plus years that you could potentially intervene if you were able to identify this state of insulin resistance or the likelihood of the state of insulin resistance.
Absolutely. Yeah. I mean, you hit it right there. Like we're thinking about beta cells and we're trying to preserve as much of that beta cell function as possible. So the earlier we're identifying any kind of insulin issue, the earlier we can help to intervene and then again, prevent that progression. So I love that you mentioned like the idea of us sitting and waiting, because I really do think that it's been taught to us that once we capture prediabetes, like that we've done it, that we've captured disease early, that we can be preventative, and that is the test. But honestly, capturing insulin resistance comes even before prediabetes. So that is where prevention really lies. once we get to prediabetes, it's more about control at that point, and it is really more about management and potentially even medication. So insulin resistance and capturing that is actually going to be, I think, where the big change takes place.
Yeah, that's so powerful, Jesse. I think that, there are so many providers out there, like I said, that, you know, want something more, right? They don't want to necessarily be sitting and waiting for that A1C or that glucose to become abnormal, but, didn't have any type of commercially available laboratory insight that will allow them to see where they are on that path of insulin resistance if insulin resistance is present. So, it's awesome that we have that available and that we can utilize that and identify these patients that are at risk. So I think it's important to cover some details about the insulin resistance panel with score, IR panel with score, for listeners that are unfamiliar with it. So the IR panel with score utilizes a fasting insulin and C-peptide to evaluate the likelihood that an individual is currently insulin resistant. So again, fasting insulin, C-peptide utilized to evaluate the likelihood of insulin resistance. So the insulin and C-peptide are used in an algorithm to calculate a score from 0 to 100 to indicate, again, the likelihood of having insulin resistance. As you can see here, the scores are broken down into 3 ranges: less than 33 normal, 33 to 66 in moderate risk range, noting that the patient is greater than 4 times more likely to have insulin resistance, and greater than 66, greater than 15 times more likely to have insulin resistance. So how is the IR panel with score interpreted? This isn't a positive or negative test. It's a probability.
So I see on the slide it mentions the insulin suppression test. Was that validated against the gold standard when you're assessing insulin resistance?
Yeah. So the IR panel with score was validated in a Stanford University study against the insulin suppression test for insulin resistance diagnosis. So gold standards for assessing insulin resistance include the insulin suppression test, and then the euglycemic clamp test. So those are the 2 gold standards for assessing IR. But if you know anything about the 2 tests, they're time consuming, technical, labor intensive, completely impractical for primary care providers, right? So both tests take, a couple of hours, multiple blood draws, IVs, multiple medications, potentially. So again, not realistic for being utilized in anything but a research setting. The IR panel with score outperformed HOMO-IR, triglyceride to HDL ratio, and it also outperformed insulin alone and C-peptide alone.
That's interesting. So is there a difference in the way that the insulin and C-peptide are measured in this test?
So the way that they are measured, the insulin and C-peptide are different within this test. So it utilizes liquid chromatography tandem mass spectrometry. So traditional insulin and C-peptide assays are immunoassays. There can be a substantial amount of variability that can occur with that type of assay. The mass spec really allows evaluation of only whole, intact, biologically active analytes or biologically active particles, so giving a more accurate representation of each testing component.
I love the visual that we get at the end because it brings this like ultra complex process into something that's really easy to read and interpret for providers and for patients.
Jesse, who are you utilizing this on in clinic? So who are you considering, okay, I want to check an IR panel with score for this patient?
So when I'm thinking about like high risk patients, it's not always like grandma with the 16 comorbidities. I mean, we're thinking about people that have family history of cardiometabolic disease, people with higher BMIs, history of gestational diabetes, that metabolic syndrome criteria, individuals that have like features of insulin resistance, like hypertension, the central obesity, acanthosis nigrans, and PCOS. And I think PCOS is one of those that I see vastly just like overlooked. And I think if you're seeing a young woman with irregular periods and they're having a hard time losing weight, hirsutism, I mean, those should all get our suspicions up for something more going on there, especially insulin resistance and PCOS.
That's helpful. I think, framing context of um, who to order this on is imperative, right? So, I mean, you hit um, the major indications or the major populations you need to be thinking about this test for. So, how do you feel that the IR panel with score has impacted your practice?
I think that knowing a patient's risk score is so important to helping them get to their goals and your goals for them.
Do you feel like you see an impact on patient motivation or engagement? I feel like this test is, a chance to look into a crystal ball. And if I saw a high probability that I was walking a path potentially leading toward diabetes, it would motivate me. But I wondered how this really plays out for you in clinic.
I would love to say that everybody I tell has insulin resistance and like they're maybe on the verge of developing prediabetes or diabetes, that if they change their lifestyle, like things will get better. But that doesn't always happen. Just like when you tell people they have diabetes, they don't always change their lifestyle when you know it would make a huge difference for them. You also can't assume like who's going to take your advice, right? And so it doesn't hurt to help and try to help everyone because you don't know whose life you're going to impact and who you could potentially change. I mean, you walk away from that conversation and you have another patient after that, right? But they may walk away from that conversation and you really did turn it around. So whether or not like everybody that you told to do something takes your advice because you know that doesn't happen, it's still worth the effort, honestly.
Yeah. And I mean, if we have a way to identify it and allow patients to make an more educated decision, right? To where we're putting all the cards out on the table to say, okay, I know we've talked about your weight before. I know we've talked about this before. What this test is showing us is that you do have a higher probability of currently being insulin resistant. This is again reiterating the need to make those changes and facilitating that conversation of, how can I help you? Or how can we move forward in continuing to address this? Again, it just opens that opportunity. But you're right. I mean, not everyone that gets a result within that moderate risk or high risk range is going to make changes, but it allowed them to see that this could continue to be an issue if they don't make those changes. So what about repeat testing? So are you utilizing this test in follow-up for these patients? So say you have a patient that is engaged, motivated, ready to make these lifestyle behavior changes to help assist in reducing or changing that state of insulin resistance. How do you utilize this test in follow-up?
I do see like great changes for people that are really motivated. And after we have that conversation about diet, exercise, I go over those scores with them. I kind of give it back to the patient. Like, when would you like to follow up on this again once we start implementing the specific plan that we've talked about? And sometimes it's 3 months, sometimes it's 6 months. Some of those patients that are like, I need the accountability, I want to come in a lot. I'm like, let's do this. And at first I thought like there was going to be some obscene bill for these patients, but there really isn't. Like, it's a very affordable test. It's really visually appealing for the provider and the patient. And I will say that any test you're watching for trends can be really motivating, especially when we see people trending in the positive direction.
Well, Jesse, thank you so much for joining me again today. I know our listeners are going to benefit from hearing your input and reviewing how you use the IR panel with SCORE in your practice. So thank you.
Thank you so much for having me.
For our listeners, for more information, please check out the resources listed here on the screen. Stay tuned for our next recording. We'll be covering chronic kidney disease and new test offerings that can help enhance practice efficiency and improve patient care. Thanks again for tuning in. Take care.